Welcome to the lecture under the title of Fetal Asphyxia, Neonatal Respiratory Distress Syndrome, Fetal Birth Injuries, Stillbirth, and Low Birth Weight. In brief, it's about neonatology from the prospective view of gynecology and obstetrics. By me, Mai Nabil, lecturer of gynecology and obstetrics in Tanta University Hospital. Let's start. By definition, it's an insult to the fetus or newborn due to lack of oxygen, which means hypoxia, and or lack of perfusion, which means ischemia, to various organs associated with tissue lactic acidosis, with hypoventilation and hypercarbon. There are a sequence of events in the course of fetal asphyxia running from primary apnea to secondary apnea. The difference between primary apnea and secondary apnea is very important, because if you catch a baby in a stage of primary apnea, it's reversible. You can resuscitate this baby and it can return to normal respiratory actives. But in the case of secondary apnea, it's a non-reversible situation. Talking about the etiology of neonatal or fetal asphyxia, there are 90% of the causes which are antepartum or intrapartum, while only 10% are postpartum factors or postpartum causes. Talking about the maternal factors leading to fetal asphyxia, any general disease of the mother can be a cause of fetal asphyxia, like hypertension, chronic preeclampsia, diabetes, anemia, malnutrition, hypoxia, any cardiac or respiratory disease, hypotension, intrauterine infections, and also prolonged and difficult second stage of labor. Talking about the placental causes, massive infarction, fibrosis, or abruption in the placenta can lead also to hypoxia of the baby. Also, there are cord accidents like prolapse, true knots, compression, and abnormal vessels that lead to hypoxia also. Regarding the fetal causes, the main cause is infection, intrauterine especially, anemia, intrauterine growth restriction, post-maturity, congenital anomalies, and hydrops fetal. There is a term that you must know called hypoxic ischemic encephalopathy, and we just say HIE. It means the sequelae of perinatal asphyxia. It's a very gravid sequelae of perinatal asphyxia, and sometimes it leads to death of the baby, and in some cases the survivors have permanent damage in the in assessing fetal asphyxia, we use our famous tool, APGAR scores. It contains 5 tools: the appearance of the baby, the pulse, the gramis or reflex irritability, activity, and respiratory actions. We evaluate each point, giving them 0, 1, or 2, then calculating the sum of the evaluation, giving you a very precise picture about the case of this baby immediately after birth, 1 minute and 5 minutes post delivery. How can we assess the baby with asphyxia? Perinatally, we have to be very aware of the problems that give you a very high risk for asphyxia. You have to tell the mother to cooperate with you and calculate the fetal movement count. Also, the fetal biophysical profile, monitoring the fetal heart rate, very careful progression of labor, fetal scalp pH, and also the presence of meconium is a very bad omen for. What about the systemic manifestations of a baby presented with fetal asphyxia? We can talk systematically about this picture, talking about the most gravid picture regarding the brain, the heart, the lungs, the kidneys, and also less important structures like the GIT. We talked about the ischemic encephalopathy. Also, it can lead to intracranial hemorrhage, for example, some cardiac diseases like arrhythmias, congestive heart failure. Also, in the lungs, the very important picture like meconium aspiration syndrome and any other damage to any essential. When we talk about the systemic manifestation, we have to study the hematologic picture of hypoxia very, very, very carefully, because it can lead to DIC, disseminated intravascular coagulopathy, hyperbilirubinemia, and sepsis. Also, talking about the endocrine system, it can lead to adrenal hemorrhage or syndrome of inappropriate antidiuretic hormone release. That's about the early effects of the hypoxia. What about if the baby survived this asphyxia and had some late effects? The most important is the microcephaly, because of the brain ischemia, of course, mental retardation, developmental delay, cerebral palsy, epilepsy, visual and hearing impairments, and also behavior. That's the very, very, very bad picture of cerebral palsy that all of us are afraid of. Let's talk about the second subject of us today, which is neonatal respiratory distress syndrome. What's the meaning of respiratory distress syndrome? It's an acute lung disease of the newborn caused by surfactant deficiency. Neonatal respiratory distress syndrome is the clinical expression of surfactant deficiency and its histologic counterpart, hyaline membrane disease, which is referred to as. What's the surfactant? What do you know about the surfactant? The surfactant is a phospholipid synthesized in type 2 alveoli, and it is starting to be released after from 24 to 28 weeks gestation, and it's released abundantly after 35 weeks of gestation. Its main function is to lower the surface tension of the alveoli. So if it's decreased, so the surface tension will increase, so leading to collapse of the alveoli and also respiratory distress. This slide shows the function of the surfactant and the causes of surfactant deficiency. The main functions are decrease the surface tension, as we said before, and also to promote lung expansion during inspiration, especially the first inspiratory actions taken by the baby postpartum, and also to prevent alveolar collapse and loss of lung volume at the end of expiration. What about the causes that lead to surfactant deficiency? First of all, we have to talk about prematurity. Prematurity is the main cause of surfactant deficiency. After that, infections, hemorrhages, meconium aspiration, hypoxia, and some causes of congenital diaphragmatic hernia and pulmonary hypoplasia, of course, are other causes of surfactant. This cycle shows us the pathophysiology of the hyaline membrane disease, starting by diminished surfactant, then lung atelectasis, hypoventilation, shock, leading to reactionary vasoconstriction, leading to alveolar hypoperfusion, impaired cellular metabolism at the systemic level, leading to, again, diminished surfactant, which is a vicious circle, leading to fetal asphyxia and consequently. What are the clinical manifestations of the hyaline membrane disease? It's very important to notice the full resuscitation and examination of the baby immediately after birth, because this picture usually appears within minutes of birth, may not be recognized for several hours in larger preterm. So the preterm cannot withstand the respiratory efforts for long. It can appear even late after some minutes or some hours after birth. The very important first symptom of hyaline membrane disease is tachypnea, more than 60 breaths per minute. Then after tachypnea, nasal flaring, subcostal and intercostal retractions, cyanosis, and expiratory grunting, which are the last grades of respiratory distress. Breath sounds may be normal in the beginning or diminished, and fine wails may be heard. Progressive worsening of cyanosis and dyspnea if neglected. Cyanosis and pallor increase and grunting decrease. Apnea and irregular respirations are ominous signs. In most cases, symptoms and signs reach a peak within 3 days, after which improvement occurs gradually. That's in the good cases, of course. There are many grades, 1, 2, 3, and 4 of the hyaline membrane disease, starting from mild cases that show only fine homogeneous ground glass shadowing, like the X-ray. Then, widespread or bronchospasm may be more. At last, in grade 4, complete white lung fields with obscuring even of the cardiac. How can we manage this syndrome? First of all, let's talk about the prophylaxis in the widespreadly used corticosteroid therapy antepartum. We have two drugs that can be used, the betamethasone or the dexamethasone, with specific regimens given along with in 4 doses or 2 doses according to the drug taken. Then optimal benefit begins 24 hours after initiation of therapy and lasts 7 days after the dose is completed. Early surfactant therapy also is another method of treatment of hyaline membrane disease. Prophylactically, it's used in preterm newborns less than 27 weeks gestation. If failed, only we can use the controlled pressure administration. Also, we have to take care of the supportive treatment in the form of body temperature, and the baby also is put in an isolated or radiant warmer to maintain core temperature between 37 plus or minus grade. There is another, of course, very important mode of therapy, which is oxygen therapy in the form of warm humidified oxygen. Then also it can be taken by nasal cannulas or CPAP, or in the late cases or neglected cases, we can reach up to the mechanical ventilation. There we have to pay specific attention to the surfactant replacement therapy. There are 2 types of surfactant used in the treatment: the natural surfactant, which is the bovine mainly, or porcine, used very, very widely. And also there is a synthetic surfactant, much more expensive but with less side effects, the artificial lung expanding compound. Also, there are newer surfactants, synthetic surfactants, of course, with synthetic peptides models on surfactant proteins, aerolized surfactants. There is a pharmacotherapy beyond surfactant, with which is giving hope in the incubators, like the nitric oxide release inhalers. That was brief about the hyaline membrane disease. Let's talk in the next subject about fetal birth injuries. For us as obstetricians, it's a nightmare to see a birth injury. It's an impairment of the infant's body function or even a structure due to adverse influences that occur at birth. So it's an idiopathic, or it's a iatrogenic process. Injuries to the infant may result from mechanical forces, compression or traction during the birth. What are the factors that predispose to increased risks of injury? First of all, the primiparity. Of course, primigravida is more vulnerable to birth injuries more than the multigravidas. Small maternal stature, so small pelvis, so cephalopelvic disproportion. Maternal pelvic anomalies, prolonged or unusually rapid labor. Oligohydramnios, malpresentation of the fetus, like breech, of course. Cephalopelvic disproportion, as said before, and deep transverse arrest of the presenting part of the fetus that leads to more force given on the fetus to be. Use of med forceps or vacuum extractions lead to more injury for the fetus. Virgin, internal or external virgins, and also extractions, any undue force lead to increased risk of fetal injury. Very low birth weight or extreme prematurity lead to fragile baby that cannot withstand the force given on the fetus during delivery. Fetal macrosomia over 4,000 grams. Fetal macrocephaly, meaning large head. Fetus. Okay, let's talk about the classification of birth injuries or birth trauma. In this picture, you can see the wide scale classification for the birth injuries. We classified into soft tissue, skull, face, cranial nerve and spinal nerve injuries, peripheral nerves, musculoskeletal injuries, and intra. Let's start with soft tissue injuries. There are some mild forms of injuries like abrasions, erythema petechiae, ecchymosis, lacerations, or even subcutaneous. As you see in the picture, in the first picture up there, we have some ecchymosis and some lacerations, and down there we have the fat necrosis. But these injuries, most of the time, are uneventful and end by complete healing unless infection takes place. The management only with antibiotics and conservative management, and sometimes laceration. What What about the term subcutaneous fat necrosis? It's an irregular, hard, non-padding subcutaneous indurations with overlying dusky red, purple discoloration on the extremities, face, trunk, or buttocks, may be caused by pressure during delivery. No treatment is necessary. Subcutaneous fat necrosis sometimes calcifies and leads to hard mass at the site of pressure, the undue pressure given during. Okay, there is more gravid sort of fetal injury in the sort of skull injuries. We have to differentiate these subtypes very, very, very carefully because some of them are very mild and resolve with time, but others are very gravid and can be fatal to the baby. Let's start with Caput succedaneum. Before we talk about these subtypes, I want you to take close look to this picture. You have to know the normal anatomy of the layers of the skull. Start with the skull bone with the underlying layer of dura mater and overlying periosteum with the galea or epicranial aponeurosis on top of the periosteum, then the skin. Notice that the periosteum is attached to the end of bones, while the galeal or epicranial aponeurosis is a very confluent and very communicating space overlying the skull that can accommodate large amounts of fluids, and then subcutaneous, very, very, very little amount of subcutaneous tissue with the skin overlying. Okay, if we talk about the caput succedaneum, in which layer collect the fluid leading to caput succedaneum? It's an edema, just edema, subcutaneously, of the presenting part caused by pressure during vaginal delivery. This is a serosanguinous subcutaneous extra-periosteal, and take care of this word very carefully, extra-periosteal fluid collection with poorly defined margins, and it's also non-fluctuating. Why it's non-fluctuating? Because the space is communicating, so it's non-fluctuating, it's not closed space. What about the term Cephalhematoma? Cephalhematoma, it's not fluid, it's not serosanguinous, it's blood. It's subperiosteal, not above the periosteum. It's subperiosteal, collection of blood between the skull and the periosteum. It may be unilateral or bilateral and appears within hours of delivery, unlike the caput succedaneum. It looks like a soft and fluctuant swelling on the side of the head. So it increases with time after delivery, and it is fluctuant in contrast to the caput succedaneum. A cephalhematoma never extends beyond the edges of the bone or across suture lines, and there's a very, very, very differentiating point of view because it is subperiosteal, and the periosteal is attached to the ends of bones, so it cannot cross the suture lines. This is the cranial X-ray of the girl with cephalhematoma. As you see there, it's a collection above the skull bones and under the skin. And it is very, very limited. And you can see in the picture, it's not wide spread around the skull. It's a specific point of toe. What about the very gravid and maybe fatal collection of blood? It's subgaleal hematoma, subgaleal, in subgaleal space. It's bleeding in the potential space between the skull periosteum and the scalp galeal aponeurosis, crosses the suture lines. So it's blood, but crosses the suture line. So in this space, it's very, very wide. It can accommodate very large amounts of blood in comparison to the amount of fetal circulation amount. It can lead to shock and pallor. So you can see the baby with tachycardia, low blood pressure within 30 minutes of the hemorrhage. The hemoglobin and packed cells volume start to fall very, very rapidly. You have to know that each kilo of the baby equals about 85 milliliters of blood. So it contains if it's 3 kilograms, this means only 85 by 3 millimeters of blood. So any small amounts can lead to fetal shock. It's presented by diffuse swelling of the head. Sutures usually are non-palpable because it's above it. The amount of blood under the scalp is far more than estimated. Within 48 hours, the blood tracks between the fibers of the occipital and frontal muscles, causing bruising behind the ears, along the posterior hairline, and around the eye. So if you can see the raccoon eyes, this means it's most of the cases subgaleal collection. And that's the difference between the cephalhematoma and the subgaleal hematoma. We can use aspiration of the mass in cases of cephalhematoma. If sepsis or antibiotics, hyperbilirubinemia, we can use phototherapy. Sometimes it's just conservative management, and I think it's most of the cases will be managed expectedly. But in cases of subgaleal hematoma, transfusion of blood may be required if the blood loss is significant, and also in severe cases, surgery may be required to cauterize the bleeding vessels to stop the bleeding. It's a life-threatening condition. What about the skull fractures? There are two types of skull fractures, maybe linear skull fractures or depressed. Of course, depressed fractures are more rapid because it leads to increase the intracranial tension and fatal sequelae. Talking about the last type of the skull injuries, which is the intracranial hemorrhages. If you study the intracranial hemorrhage in adult, it's the same in the fetus or the newborn. With the bleeding can occur external to the brain, into the epidural, subdural, or subarachnoid space, or into the brain parenchyma of the cerebrum or the cerebellum, or into the ventricles from the subependymal germinal matrix or choroid plexus. Of course, the baby or the newborn is more vulnerable to intracranial hemorrhage because of the soft tissues, the bleeding tendency in the newborns also. It's a fragile creature liable for intracranial hemorrhages more even than the adults. Okay, let's talk about another type of birth injuries, which is the facial injuries. Some of them are mild, like the subconjunctival hemorrhage, retinal hemorrhage, which is very grave, and other ocular injuries. And also regarding the nose, there are recorded cases of nasal septal dislocation. Talking about peripheral nerve injuries. This is a very important entity from the point of view of obstetrics, specifically the brachial plexus palsy, phrenic nerve injury, and also, less importantly, laryngeal nerve injury, radial nerve palsy, lumbosacral plexus injury. The most frequent type seen in obstetric birth injuries is the brachial plexus injuries. You have to know the subtypes of the brachial plexus injury because it's the most important and the most common type seen in the peripheral nerve injuries during birth. The first type is the Herb de Champ palsy. When the injury happens in the cervical 5 or cervical 6, commonly the Phrenic nerve coming out from cervical 3 through cervical 5 can be also included in the injury. Clumpic palsy, if the injury is lower in cervical 7, 8, and thoracic 1, but it's less common than the Herb de Champ. In clumpic palsy, sometimes the Horner syndrome is associated, and stenomastoid hematoma or clavicle is fractured, leading to that injury. The worst type, but it's less common, fortunately, is the total plexus palsy, called carier's paralysis. Of course, the risk factors for brachial plexus injury is the macrosomia, the shoulder dystocia, instrumental deliveries, and malpresentation. It's due to undue traction and in the wrong axis, undue force in the wrong axis, leading to the brachial plexus. The first type of the brachial plexus injury is the Herb de Champ. It's the most common, lack of shoulder motion, and involved extremity lies adducted, prone, and internally rotated. It's called the weighted stiff position, like you see in the pictures here. Sometimes the phrenic nerve coming from C3 to C5 is also involved in the characteristically, you can see the biceps reflex absent and the molar reflex absent, but the grasper reflex is present, and this specifically differentiates the Herbs from the clumpix paralysis, where the grasper reflex will be absent, the biceps reflex is present. It's against or in the opposite of the first type. Horner syndrome here can be included, presented by ptosis, meiosis, and anhydrosis, hematomas of the sternocleidomastoid muscle, and fractures of the clavicle and humerus may be. While in cases of total plexus palsy, the carier's paralysis, it's the most disturbing of all. Its clinical features are adynamy, muscle hypotony, positive scoff symptom. Another type is the Cough-Rate syndrome involving C3 to C4, and it's the diaphragm paralysis. It's very, very, very grave and maybe also life-threatening. Because of irregular breathing, cyanosis, pneumonia can be suggested mistakenly. Sometimes these cases are mistaken with infection. These are pictures of Erb's palsy, complete brachial plexus palsy, and Klumpig's palsy. Talking about phrenic nerve injury. The phrenic nerve arises from the 3rd through the 5th cervical nerve roots. Injury to the phrenic nerve leads to paralysis of the ipsilateral diaphragm, as seen in the X-ray or the picture above. Respiratory distress with diminished breath sounds on the affected side. Chest radiographs show elevation of the affected diaphragm with mediastinal shift to the contralateral side. Ultrasonography or fluoroscopy can confirm the diagnosis by showing paradoxical diaphragmatic movement. There are less important because it's not very common, like the laryngeal nerve injury, presented by stridor, respiratory distress, hoarse cry, dysphagia, and also aspiration. It's diagnosed by direct laryngoscopy as seen by the picture. It's treated by small frequent feedings may be required to decrease the risk of aspiration. Intubation, tracheostomy, bilateral paralysis tends to produce more severe distress and therefore requires intubation and tracheostomy placement more frequently. It's very, very grave and maybe a cause of. Okay, talking about cranial nerve and spinal cord injuries, it's very fatal, very grave, but less commonly seen because it needs very, very vigorous and very unrational force on the baby, and also on it needs fragility and prematurity of the baby to be delivered normally, and that's not the case in most of the cases. The very frequent or the most important types of these are the facial palsy and the spinal cord. The facial palsy is the same like as you see in the adults. The main cause is pressure on the facial nerves, especially using forceps during delivery. Of course, undue force or incorrect placement of the blades of the forceps. The picture is the same like the adult cases. Prophylaxis is better, but if it happens, neurosurgical repair of the nerve should be considered only after lack of resolution during the first year of obstetrics, resolved completely without any intervention. I am not going to speak in details about the spinal cord injuries because it's a subject of neurosurgery more than obstetrics and gynecology. Your role is just to notice some abnormality, and then you have to refer to the neurosurgery. The main cause, of course, is excessive traction or excessive rotation. It's not just traction, it's also rotation during delivery. Failure to establish adequate respiratory function is the main fatal presentation of this sort of spinal cord injury. The baby usually is posing as frog, oscillation test is positive. The clinical findings are different regarding the level of trauma. Usually lesions above C4 are almost always associated with apnea and maybe death. Lesions between C4 and T4 may have respiratory distress secondary to varying degree of involvement of the phrenic nerve and innervation to the intercostal muscle. Let's speak also about musculoskeletal injuries like clavicular fractures, which is very mild and can resolve spontaneously without any intervention. Fractures of long bones, which is more frequent even with normal delivery or even in cesarean section, especially in breech extraction. Also, sternocleidomastoid injury, torticollis. As you see in the X-rays here, you can see a lot of types of long bones. The humerus, maybe the femur sometimes, are broken due to undue force. You have to be very, very careful while manipulating the baby. You have to manipulate the joints, not the bone or the viscera, to avoid any trauma. You have to pay special attention to the sternomastoid injury because it's congenital and it's your fault, the congenital muscular torticollis. It leads to atrophic muscle fibers surrounded by collagen and fibroblasts, tearing of the muscle fibers of the facial sheath with hematoma formation and subsequent fibrosis. The presentation is head tilt toward the side of the lesion and rotated to the contralateral side. The chin is slightly elevated. If a mass is present, it's firm, spindle shape, it's calcified hematoma usually, immobile, and located in the mid portion of the sternocleidomastoid muscle without accompanying discoloration or inflammation. These are the very, very sad pictures of the injury. It usually needs some active and passive stretching and maybe surgery after. Finally, we can talk about intra-abdominal injuries. It's very, very grave and needs very, very undue force in the baby. Again, liver hematoma, splenic hematoma, adrenal hemorrhage, and renal. Okay, that's the end of our notices about the birth injury. Let's talk about another subject called stillbirth. I need you to take care of the vocabulary, terminology, using terminology in obstetrics and gynecology. What's the meaning of stillbirth? Stillbirth means no evidence of life after birth beyond 20 weeks. What are the evidence of life after birth? Taking breath, movement, or even one cry is an evidence of life. So absence of any of these can lead to the term of intrauterine fetal death or stillbirth. Okay? What's the difference between the terms stillbirth and intrauterine death? The subclassification gives you a good point about what's the meaning of stillbirth. Stillbirth is classified into fresh and macerated. Fresh death means an incident happening during the birth or just before birth, which leads to noticing that it's a default of the quality of intrapartum care. But if it's macerated, so it's of course more than 12 hours before delivery, so it's retained, so the cause is not the intrapartum delivery. But if you use the terminology intrauterine death may be early or late. Early from 20 to 27 weeks. Before 20 weeks, it's abortion or miscarriage, not intrauterine fetal death. But if you use the term late intrauterine fetal death, it's meaning that the baby died after 28 weeks gestation and before delivery. Talking about the etiology of stillbirth, it's unknown in half of the cases, while in the other half, the most common causes are fetal causes, then placental causes, unexplained causes, and at last the maternal. What are the maternal risk factors for stillbirth? Take into consideration that obesity is a proven modifiable highest ranking cause of the maternal causes of intrauterine fetal death. Maternal age more than 35, smoking, alcohol or drug abuse, infections, medical treatment like diabetes, hypertension, and thyroid diseases, pre-existing diseases like anemia, heart disease, epilepsy, autoimmune disorders, Rh incompatibility, hyperpyrexia, thrombophilias, trauma, cholestasis of pregnancy, and also any obstetric condition like abruption, premature rupture of membrane, multifetal gestation, or even labor-related conditions like prematurity, dystocia, and the fetal causes are mainly multiple gestation, intrauterine growth restriction, congenital anomalies, infections, eye drops, G6PD deficiency, and vertigo. The placental causes are mainly abruption, cord accidents, placental insufficiency, placenta previa, twin-to-twin transfusion syndrome, chorioamnionitis, premature rupture of membrane, fetal-maternal hemorrhage, and also iatrogenic like external cephalic version or dry. The diagnosis mainly presented by absence of fetal movement. Then the signs are retrogression of the positive breast changes per abdomen, gradual retrogression of the height of the uterus, uterine tone is diminished, fetal movement are not felt during palpation, fetal heart sound is not audible. You can diagnose it 100% by the ultrasound. You can also diagnose if there is any associated features like oligohydramnios or hydropes. In the past history, they used X-ray, which is obsolete nowadays, to diagnose the intrauterine fetal death, showing the Robert sign, Spalding sign, ball sign, helix sign, and the crowdness of the rift shadow. You have to know it just for the oral discussions, knowing something about it. Okay, in the management plan for these cases, you have to take very, very, very detailed history. You have to examine the case very thoroughly for the stillbirth infant, the umbilical cord, the placenta, and the amniotic fluid. You can do fetal autopsy and also karyotyping. They are very, very useful for the future pregnancies. Placental investigation and maternal. These are a list about the gross description for the infant, the umbilical cord, amniotic fluid, placenta, and membranes, and the changes that you can see in the stillbirth. For example, if you examine the infant, you can see malformations if there is any, skin staining, degree of macerations give you feedback about the timing of death, the color of the baby, if it's pale or plethoric, the cause can be evident here. The umbilical cord, if you see a cause like hematoma, stricture, knot, the amniotic fluid color is very, very, very important in these cases. It can be meconium stain, greenish, or red in cases of blood abruption, for example. And its volume, if you see small amounts in oligohydramnios, it's a cause also, or polyhydramnios in cases of edema of the baby. You have to examine the placenta also if there is structural abnormality, filamentous insertion of the cord, or hydropic changes. The fetal autopsy is recommended to be done, and also karyotyping. It's crucial for the future pregnancy. It can be done after good counseling of the parents. Also, placental investigations like chorionicity, cord knots, vessels, thrombosis, infarcts, vascular malformation, size of infection, placental block 1 by 1 centimeter below the cord insertion is very important for examination. The umbilical segment, for example, 1.5 centimeter is enough to be examined. Placental swabs for infection, bacterial cultures for Escherichia coli. The maternal evaluation contains complete blood count, hemoglobin electrophoresis, diabetes testing, additional tests like the Hypoxic test or serological test for infection can be also suggested for the cause of intrauterine infection, which gives you a very important data for the current or for the future pregnancy. Also, you have to test the mother for antiphospholipid syndrome because it's a cause of thrombophilia and a very important cause for intrauterine fetal death, which can be prevented in the future pregnancy. The management. What can you do for this situation? It depends about single or multiple gestation, gestational age and death, the parent's wish. You cannot do anything against the parent's will. So you can just do expectant approach or into the previous factors. It can be complicated by infection, postpartum hemorrhage, retained placenta, abruption, disseminated intravascular coagulopathy, shock, renal failure, sepsis, or even maternal death if in the very, very, very near. But you have to pay attention for the management of future pregnancy in several stages. First, preconceptionally, or the initial prenatal visit, you have to take very detailed medical and obstetric history about the previous pregnancy and what happened there, evaluation and workup of the previous stillbirth, determination of the recurrence risk for the recurrent causes, smoking cessation, weight loss in obese women, and this is very important, genetic counseling if there is any genetic condition existing, medical probes like diabetes, thrombophilia workup. You have to do a lot of support and reassurance during this. Then, during the first trimester, you have to give very, very precise dating sonographically. First trimester, pregnancy-associated plasma protein A, B, HCG, and nuchal translucency, the soap markers for any anomaly. And also you have to give folic acid to prevent the anomalies. The second trimester, you have to do fetal ultrasonographic anatomy survey at 18 to 20 screening, maternal serum screening, the credible markers, and also the blood investigations for the diseases can be present in. During the third trimester, you have to calculate again the sonographic screening for fetal growth restriction after 28 weeks of gestation, admission at critical period in high-risk cases. Kick count starting at 28 weeks of gestation gives you an impression about the well-being of this baby. It's a complex procedure called antepartum fetal surveillance starting at 32 weeks or 1 to 2 weeks earlier than prior stillbirth. Weekly fetal heart rate by physical profile and Doppler. You have to do again. So that was about a small idea about stillbirth and intrauterine fetal death and how to think about these things. Now we shift to another subject called perinatal mortality. It's a sort of statistics you have to calculate in every country to evaluate the healthcare provided. So there is some terminology that you have to study very well during this calculation. First of all, the perinatal period commenced at 28 completed weeks of gestation, which is the time when birth weight is normally 1 kilogram, and ends 7 completed days after birth. This is the perinatal period. Before 28 before delivery, 28 completed weeks till delivery, then postnatal till 7 completed days. Okay, the neonatal period commences at birth and ends 28 completed days after birth. So it's divided into early neonatal period and late neonatal period. The early is the first 7 days of life, and the late are from 7 to 27 days of life. You have to know these terms very well because there is very specific ratios and grades regarding each. So the perinatal mortality is all fetal and early neonatal deaths weighing 1 kilogram or more between 28 weeks of gestation to first week of neonatal life. That's according to the WHO. So if you calculate the perinatal mortality rate, it's expressed in terms of perinatal deaths per 1,000 total birth. We divide it by the total birth as all. Perinatal mortality in developed countries is less than 10 per 1,000. So I want you to concentrate with me. There are two terms, perinatal mortality rate and perinatal mortality ratio. The perinatal mortality rate is the number of fetal and early neonatal deaths divided by the total births, live and death, multiplied by 1,000. While the perinatal mortality ratio is the fetal and early neonatal deaths, the same numerator like before, but divided on the denominator live births only, discarding the death, also multiplied by 1,000. What are the causes of perinatal mortality? It's maybe antenatal, intranatal, or postnatal. It's a very important reflectors of the health care in every country. The antenatal causes mainly are maternal diseases like hypertension, cardiovascular, diabetes, infections, anemia, any other disease in the mother. While the intranatal are mainly birth injuries, asphyxia, prolonged effort time, obstetric complications. So it's a very, very good reflector of the health care during the delivery. Postnatal causes are more of concern to the neonatologist. It's like prematurity, respiratory distress syndrome, respiratory and alimentary infections, and congenital anomalies. What are the prophylactic measures to decrease the perinatal mortality rate? For every cause, before you have to think to decrease the risk for the baby, like proper antenatal care, prevention of premature birth, providing better care and monitoring during the intranatal period, regular use of parthographs and timely interventions, intensive care of very low birth weight and sick neonates. So you have to improve your screening tools, your healthcare provision in obstetrics and delivery units, and also in the incubators and the neonatal care delivered to every birth. That was our talk about the perinatal period and perinatal mortality rates and ratios. Let's talk about our last terminology today, which is low birth weight. What do we mean by low birth? Low birth weight is any infant with a birth weight of less than 2.5 kilograms within 1 hour of birth, regardless of the gestation age. So we are not talking about the prematurity or post-maturity or intrauterine growth restriction. It's as a whole low birth weight. It's graded into 3 grades. Low birth weight from 2,500 grams to 2 kilograms. Very low birth weight from 2 kilograms to 1 kilogram. And at last, the extremely low birth weight below 1 kilogram. Low birth weight is divided mainly into 2 big categories: the preterm and the small for date or the intrauterine growth restriction on the other side. The preterm is babies below 2.5 kilograms, less than 37 completed weeks of gestation, and it accounts for 1/3 of low birth weight. While if we talk about small for date or intrauterine growth restricted babies, they are babies less than the 10th centile for gestational age, and they account for 2/3 of the low birth weight neonates. The causes are either preterm or intrauterine growth restricted, as we said before. In nearly 50% of cases of low birth weight, the cause is not known. In remaining 50%, the causes are grouped into medical. The medical causes are mainly maternal, placental, or fetal causes, while the social causes are poverty, illiteracy, ignorance, poor standards of living, lack of knowledge on family planning, and early marriages or smoking. So this is a very important point, that it's the modifiable. Most of the modifiable causes are the social causes, but there are some other causes like medical disorders that can be decreased but not eliminated. So low birth weight will still very challenging problem in obstetrics and also. Why it's very important? Because low birth weight babies have a lot of problems, mainly birth asphyxia, hypothermia, feeding difficulties, infections, hyperbilirubinemia, respiratory distress, retinopathy of prematurity, apneic spells, intraventricular hemorrhage, hypoglycemia, and at last, metabolic acidosis. Not least, there are a lot of problems that should be taken in consideration while putting a management plan for low birth. For small for dates, it's a little bit better prognosis, but again, they have some problems specific for them, like birth asphyxia, meconium aspiration syndromes, hypothermia, hypoglycemia, infections, and polycythemia. While putting a plan for low birth weight babies, depending on the birth weight, you can categorize them into 3 categories. The first one is the low birth weight, requiring special care at home, less than 2 kilograms, requiring special care at hospital. But there are some neonates between 1,800 grams and 2 kilograms. They are stable and hemodynamically good. They require kangaroo mother care. This is a terminology changing the plans of management from only hospitals into they can be taken care at home, but with special. This is the picture of a kangaroo mother care. It's first suggested by Edgar Ray in Colombia in the 80s. It refers to care of the preterm or low birth weight infants by placing the infant in skin-to-skin contact with the mother or any other caregiver. For the countries, it decreases the cost taken in the incubators and decreases the supplementation used in treating this problem. And in the mother, it keeps the contact between the mother and the baby. And also for the baby, it keeps the relation with the mother and also with the exclusive breastfeeding, solving the problem of hypothermia by direct skin-to-skin contact all over the period until the baby comes above 2 kilograms. Then at that point, it can be taken care at home by the neutral care. I hope I gave you a very simple and very brief lecture about the most common problems of neonatology from the prospect of obstetrics. And it would be fun for me, and it would be very pleasure to be among you in the regular days. But what can we do in our days if Corona nowadays? I will be very happy to receive any of your questions or notices, even on my personal contact available with you. Hoping to see you very soon and hoping to be among you very soon. And I hope you very successful life in the coming days. Thank you. Mai Nabil, lecturer of obstetrics and gynecology, was with you for the last hour. Thank you again.